Hello, and welcome to episode 3 of the Ask the Expert podcast series, a series of podcasts that features clinical experts in the world of bleeding disorders answering questions from me, your host, Patrick James Lynch, as well as questions that have been submitted by members of the bleeding disorders community. This episode features Dr. Robert Sidonio. Dr. Sidonio is an assistant professor of pediatrics at Emory University, and he's also the Clinical Director of Hemostasis and Thrombosis at Children's Healthcare of Atlanta. Dr. Sidonio has the unique distinction of being an expert in women with bleeding disorders, and as he talks about coming up here in a moment, is sometimes the only male in a room speaking in front of 100 plus women with bleeding disorders, a unique distinction that Dr. Robert Sidonio has. But I chose to have him on the podcast for this episode to talk specifically about just that, women with bleeding disorders. As you may know, BloodStream Media has recently released our first Bloodline series, our series of podcasts that are deep dives into the topics that matter most, and we kicked it off with a series on von Willebrand disease. And while von Willebrand disease does occur about equally in men and women, it is more commonly diagnosed in women than men, and it led to a lot of conversations with women patients and clinicians about women with bleeding disorders in particular. And for those who were engaged in the World Hemophilia Day awareness campaign from the World Federation of Hemophilia last month on World Hemophilia Day, April 17th, there was particularly a focus on women with bleeding disorders. So Dr. Sidonio here in this conversation helps me, a guy with a bleeding disorder and an active member of the community, understand a little bit more of the community of women that he sees on a regular basis, what their challenges are, what the trends are, both clinically and from an advocacy perspective, and his outlook on what the road ahead may have in store for women with bleeding disorders. That conversation with Dr. Sidonio is coming up here in just a moment, but before we get to that, I did just mention the Bloodline series on von Willebrand disease, and if you haven't checked out BloodStream Media's other podcasts, that is the BloodStream podcast, our monthly flagship podcast, as well as the Powering Through podcast featuring live panel conversations on obstacles and challenges, visit bloodstreammedia.com, where you will find pictures and links to the websites of each of those respective podcasts. You can download and subscribe to Ask the Expert, Bloodline, the Powering Through podcast, or the BloodStream podcast by going to bloodstreammedia.com and following the links to download or subscribe on your preferred podcast player. And if you have a topic that you would like covered in a future Ask the Expert episode, email us at mailbag@bloodstreammedia.com. You can also reach out to us on Facebook, facebook.com/bloodstreammedia, or reach us on Twitter, where our handle is @bloodstreaminfo. And with that, let's get into the conversation with Dr. Robert Sidonio, speaking all about the world of women with bleeding disorders. To get us started, help me understand some of the recent history of women with bleeding disorders. There's certainly a raised level of awareness this year, in particular with the World Federation focusing on women with bleeding disorders as part of their World Hemophilia Day awareness campaign. And in the last few years, we've definitely seen a surge of awareness. But can you go back a little bit and just give us kind of, the recent history of women with bleeding disorders in the U.S.?
So if we're talking about women with bleeding disorders, and specifically those that are hemophilia carriers, the studies don't go back that far. The first description was in 1951, in which half of the 19 carriers in the study reported excessive bleeding after they had their teeth removed. And there were very few studies after that for the next few decades. And it really wasn't until 2006, so only 11 years ago, when Dr. Plug published a nice article in Blood, sort of the premier magazine for hematologists, that noted that carriers specifically with levels in the 40 to 60% range had an increased bleeding risk that could not be completely explained by their level, because as you know, the normal level, depending on where you read, is approximately 50%, and patients above that threshold should not really have any excessive bleeding tendencies. And what she showed is that they did seem to have increased tendency to bleed after getting cut, higher likelihood to develop joint bleeds, a higher likelihood to require treatment after they had their teeth pulled, and then requiring transfusions or treatment after surgery. And so this was the biggest, probably best put together paper that demonstrated this risk. And it also highlighted that there were quite a number of carriers that had levels that were in the male hemophilia range.
What's the next step? How do we get from where we are today, which sounds like we're on the right path, but what's the next step toward continuing to ensure, I guess, number one, that the clinicians at treatment centers, those who are expected to be most expert, have a full understanding of the women that come through the clinic? How do we take the next step forward in that regard?
Well, I think, for me, I always think that the best thing that helps move continues to move this forward is high quality data and well done trials and retrospective studies. And that's sort of what we're doing as our research group at Emory, and then others are as well. And so myself and Victoria and Paula James in Canada are conducting a study where we're looking at the response to carriers with stress. And so one of the notions that we've had was that it's not the level that predicts the amount of bleeding like it would in a male with hemophilia. It's actually the ability for that woman to mount an appropriate response to stress. And something that we've noticed is that when women are under stress, their levels don't seem to rise as rapidly as a woman that didn't carry that hemophilia mutation. And we actually demonstrated that in a trial. We presented this results, the interim results, at the most recent HTRS meeting. They actually had a blunted response, meaning that they can get the level up, their factor VIII level up in the first couple of hours, but then there's a rapid decline. And that rapid decline may likely have to do with the fact that they have a hemophilia mutation, but also could be the reason that there's an increased bleeding tendency. We are, Christina Haley, Shirley Abrams, and myself are working on something called the Athens Dream Award. And what we're going to do is we're going to take all the women that with bleeding disorders that are enrolled in the American Thrombosis and Hemostasis Network database, and we're going to go back to a certain number of centers and ask more detailed questions that we didn't get around in the first go-round. And we're hoping to learn what strategies work for controlling of heavy periods, and learn a little bit more about the quality of life and sort of the patient journey of those that have bleeding disorders. And then at our own center, we're actually doing a prospective study looking at the quality of life in these carriers so we can drill down where the reduced quality of life is. There was a recently published study demonstrating that caregivers, which were predominantly hemophilia carriers, there was, increased anxiety, depression, pessimism, and a general reduced quality of life. We want to know why that is so. And one of the things that we wanted to look at is relationship stress. As you know, it can put a big strain on relationship if you have a child with a chronic disease such as hemophilia, particularly early in life, as many of the males don't have, the fathers involved have no understanding of hemophilia, and that can put a lot of strain on their relationship if they weren't prepared for that. So we're actually going to look at things like sexual quality of life, which I think is understudied. And then we're doing our first clinical trial looking at how women respond to extended half-life factor products for their heavy periods. And that hopefully we'll have the first patient in sometime in July. So these are some initiatives that we're doing. NHF has definitely had a renewed interest. They've revived their Victory for Women project and their website, which looks fantastic. They collaborated with the CDC to work on a project called betteryouKnow.org, which helps provide some tools for women at risk for bleeding disorders. And then a great website called Let's Talk Period, which I think is very clever, which is a focus on heavy periods. And it's a Canadian website run by Paula James. in which patients can actually go on, or potential patients can go on, and look and actually calculate what their bleeding score is, and provide that information when they go to the clinic when they're being investigated for a bleeding disorder. So there's a lot of initiatives in addition to our overall quality improvement project, in which we're trying to make sure that we are doing rigorous testing on every adolescent girl that presents with heavy periods, particularly with a focus on von Willebrand disease. So I think there's a lot that's going to go on in the next couple of years, which I think is very exciting for this community. And I'm very hopeful that we'll have a whole stack of manuscripts that come out that will continue to support what we've always known, is that there's a poor quality of life, and that these women with bleeding disorders have unique bleeding challenges and bleeding symptoms that we need to pay more attention to.
One of the things you said that stuck out to me was the relationship between stress and bleeding patterns. And correct me if I'm wrong, but it sounded as though the factor levels may not necessarily contribute to the bleeding patterns as much as stress. Is that accurate?
Well, what happens is that, in males that have severe hemophilia, if they're under stress, medical stress, or just stress from whatever, their level doesn't really move at all. It just doesn't move. And similar in moderate hemophilia, so those with 1 to 5% levels. But we do know that males with mild hemophilia, just doing warm-up exercise for 15 minutes can actually elevate your von Willebrand factor and factor VIII for a temporary period of time, but that may actually protect people from bleeding. And so this has been evaluated by Ritin Kumar in an exercise study in which he basically took some adolescent boys with hemophilia, put them on bicycles, made them bicycle until they were exhausted, and then looked at how their body responded to that stress on their body. And so we wanted to look at this theory and in carriers. So we actually took normal women. We gave them a medicine called DDAVP, which is sort of a medical way to induce stress. Eventually, we're going to do the same bicycle experiment, but we gave it to both the normal women and to those that were hemophilia carriers. And we noticed that the carriers were not able to elevate their factor VIII and sustain it as long as a normal woman. So this would mean that if you're a carrier and let's say you fell, the stress on your body would elevate your levels, but your level would not be as elevated as long as a normal person. And so we feel like that may actually contribute to some of the bleeding. For example, if you had a surgery and you're a carrier, maybe initially you'll be able to respond and get your level up. But in the next couple of hours, your levels are dropping, and that's where your risk of bleeding can occur. And I've seen multiple hemophilia carriers bleed with tonsillectomies. And I think that probably played into why they, developed late bleeding, because they didn't bleed on the first couple of days. They bled 5 to 6 days later. And, we're looking at various other things, but I think that one may actually, be the answer. So we have 17 patients that we've looked at. And so, we'll be done with the study and, by the end of the year. So we'll have our answer by then.
You had mentioned also the impact that having a bleeding disorder can have on sexuality, sexual health, and sort of alluding to the comprehensive psychosocial impact, in addition to the physical impact with regard to sexual health that a bleeding disorder can have on somebody. That was certainly something that became apparent to me during the process of creating the von Willebrand podcast series for Bloodline. Can you speak a little more about, in particular, how sexual health and the way that impacts partnership and significant others, how that's played a role in the way you consider treating and managing or helping manage women with bleeding disorders?
There have only been a few studies that have looked at the quality of life. And if you've ever done these quality of life studies, there are these very generic questionnaires, and they may just sort of touch on the issue. And what we've seen is that, general health, pain seem to be reduced in carriers when you compare them to normal women. And some of the other studies that we've done have shown that there seems to be an impact on their relationship. as I go to a lot of meetings and give talks at mostly patient advocacy meetings, I hear over and over again that women they're very stressed out about the issues about heavy menstrual bleeding. And when you look at hemophilia carriers, about 70 to 80% of them have heavy periods. And sort of thinking about this, it's very difficult for a woman that has very irregular heavy periods to be able to have a good, sexual relationship with their partner, because it can lead to, excessive pain. It may be something that's embarrassing, particularly in the younger teenagers. And oftentimes carriers aren't ready to discuss, the fact that they are a hemophilia carrier with someone maybe that they're not, they're ready for an intimate relationship, but they're not ready for maybe a long-term relationship. And so I think that just puts a lot of stress on them. And I've had hemophilia carriers call me, prior to their first sexual experience or immediately after, asking about what to expect, which, always is surprising that they would call me. I told them to first call their mother instead of calling me. But I think it's sort of, they have a lot of anxiety about what it's going to cause. Is it going to sort of freak out the guy that they're with? But you see this over and over again in different testimonials about how it puts stress on their relationship. And so I think it's really important that we focus on really managing their periods well, making it something that is something, and there are various ways of managing it, but I think it's important to pay close attention to making the periods less irregular, less painful, and then obviously reduce how often they have it. And that often takes trial and error with multiple different management options, which could include hormonal, pills like birth control pills, IUDs, and then sometimes the use of antifibrinolytics or factor replacement. So I think, we may not think it's a big deal that they have a couple extra days that are heavy, but it really does have an impact. And so I think it's important that the providers ask those additional questions, because I found that a lot of teenage girls cannot stand having irregular periods. They'd rather have heavy regular periods than, even light irregular periods, because it's very hard for them to plan and predict, and do things in their schedule when they're having to worry about having a period at any moment. So I think it's really important to pay attention to those, because you can just tell by seeing the patients that we manage their periods well, their quality of life is significantly improved, and they're just significantly more happy because they're in more control of their menstrual bleeding.
It's interesting, when you mentioned the impulse to contact you perhaps before contacting their mother about their first experience. In a way, it suggests to me that the bleeding disorder really is having a large role psychologically in thinking about that moment. If the first impulse is to reach out to the doctor, that above the parent, that communicates something to me. So just kind of interesting. You touched on sort of birth control options, and I know a little bit about this, but I've even had conversations with some women with von Willebrand disease who don't necessarily feel like they have full information about how various birth control options can interact with their blood disorder. Can you talk a little bit about that?
Yeah, so there hasn't been a lot published on how should we approach heavy menstrual bleeding in those with bleeding disorders, and specifically hemophilia carriers and von Willebrand disease. What we do know is that, myself and other providers that do a lot of this, like Aisha Zaya and Christina Haley and myself, we know that for the majority of women with mild bleeding disorders, birth control pills are a really good first option. There are clearly people that have adverse reactions, and there's contraindications. For example, in those people with bad migraine headaches, estrogen is not a good option. Or if you have a history of high blood pressure, then the estrogen-containing birth control pills aren't good options. And and some people are turned off by some of the side effects, like, for example, with Depo-Provera, which there is a, definite history of weight gain that's associated with that. So a lot of carriers are not going to be interested in using that methodology of menstrual control. But for the majority of our patients, even hemophilia carriers, and those with von Willebrand disease, we often will try a low-dose combined oral contraceptive. It often may require a taper, so high doses at first and then taper down. And then if that doesn't work, we'll try some progestin-only options. And we have some really good success stories with just using either one of those. I have a teenage girl who is a carrier that has a level of 1% because she's what we call lionized. And she has multiple female members that have low levels. And she hasn't had a period for 2 years by taking this pill every day. It's completely stopped her period. And so that's a great option for her. And then we have other patients that are very difficult to manage that often require multiple options, such as placement of IUD and starting factor prophylaxis. And sometimes that's the option that's needed. It can be a little bit more challenging in the von Willebrand patients because we know even less how to manage that. And as you know, a lot of the von Willebrand patients didn't grow up in the IV culture. So in hemophilia, everybody in the family, all the women for sure know how to place an IV and infuse factor, and most of the men do as well. But in von Willebrand disease, we don't infuse as often with factor, and it's not a skill that's needed as much in the majority of the patients. And so most of them are very reluctant to want to attempt to use factor replacement for their periods. I think that's changing in the last couple of years. More are willing to try it. And for a couple of patients that we have, that's been the best option for them. They're on, 3 times a week for their periods, and, they do the infusions then, and it's really helped them out. And so it's just about being patient and trying multiple options. For some patients, if they are willing to live with that and if they don't want to try anything, that's fine as well, as long as it doesn't lead to any kind of severe anemia. We're okay with that.
Right, just making sure that they know what their options are.
Exactly.
So we've talked a bit about women with hemophilia or carriers or mild hemophiliacs, symptomatic carriers, whatever term feels appropriate, and women with von Willebrand disease. I'm curious, do you also see through the clinic women with some of the more rare factor deficiencies, factor 5, factor 10, any of those?
So yeah, we've created here a special clinic. We have our comprehensive clinic on a certain day, and certainly the adolescent girls and women with bleeding disorders can come that day. But what we're trying to do is we have a GYN that comes on another day that we've recently hired to be part of the comprehensive care model. As you know, that usually involves a physician, a nurse, research nurse, social worker, and there may be some other people that are involved. We're blessed to be able to have a dental hygienist that works in our clinic, which has been fantastic to have. And then we have a physical therapist that can help out, particularly with some of the older gentlemen. But we felt like, we wanted to better serve the needs of this growing population of adolescent girls and women with bleeding disorders. And I found it very frustrating to be able to find enough GYNs that were adequately trained and understood the unique challenges that these women have. And so instead of complaining about it, we just sort of we've been educating ours locally and actually have hired one to come on to our clinic and see these girls with us. And that's been very helpful, that we can go in and discuss together in front of the patient what we think is the best option. Obviously, incorporating what the mother and the daughter would like. And I think that's been very, very helpful. And I think it gives these girls a reason to want to come to the clinic, because a lot of times a lot of GYNs are very uncomfortable seeing girls under the age of 15. And so we do have, those with rare bleeding disorders. We have a teenager with Glanzmann's thrombocythemia, a couple of girls with that. And we have a couple of various rare bleeding disorders as well with Bernard-Soulier and various other factor deficiencies that fits in the broad category of rare bleeding disorders, which also includes factor VII deficiency. So we see all those patients in the clinic, regardless of their factor deficiency or how severe it is, to help better manage their periods. Because I think that's the key to a lot of their quality of life, is getting that under control.
And predictable, as you had said before, seems to be of high priority.
Yes.
As these girls and adolescent patients age, and I'm sure it's quite different if you're dealing with factor VII deficiency, factor VIII deficiency, von Willebrand deficiency. It's certainly different. But in broad strokes, are there different challenges that present at different landmark moments through a woman's life when she has one of these bleeding disorders?
Yeah, so, in most of the women with bleeding disorders, oftentimes their presentation is different. And when you're talking about specifically, for example, von Willebrand disease, the average male with von Willebrand disease, their most common bleeding symptom that leads to a diagnosis is nosebleeds. And for women, the most common bleeding symptom by far is heavy menstrual bleeding. It's the majority of the patients are diagnosed that way. And when we did a medical claims study, we were surprised at the impact on the healthcare system there was. As most people know, von Willebrand disease, there should be equal frequency in males and females. And yet, when we looked at a medical claims data set, the majority of patients identified were women. And I think it might be because we're doing a better job of identifying them around the time of their period. And then it had a disproportionate impact on the healthcare system. So 80% of the claims were from women in the U.S. in the last couple of years. And so we know that they have a disproportionate impact. And so for women, oftentimes they may have very little bleeding symptoms early in life. And they may experience the same one as males, but oftentimes they have less of them. And then the unique challenge of menstruation can be quite distressing. And sometimes it's one of these taboo topics that, particularly in America, we don't really talk much about. And it's pretty routine for us to see girls present with very heavy periods and severe anemia to the point where they need to get a blood transfusion. That's something we're trying to put a stop to, because I feel like that shouldn't happen this day and age. But I think sometimes the mothers have minimized their bleeding symptoms, and so when their daughters tell them that they have heavy periods, they may say, well, I have heavy periods as well, and your aunt does too, but it may be because they're all carriers. And it doesn't mean that we should minimize them just because, you have a male with hemophilia that has more bleeding symptoms. So I think that creates a unique challenge. The first couple of years can have very irregular periods and quite heavy periods where women may bleed for weeks on end. I think once we get past that, there's some other unique challenges. Obviously, trying to prepare, for family planning is very important, as you know, with planning for potential of having a child with a bleeding disorder. So I think that's really important. And I still this day and age, we still get phone calls for women that say that they mentioned it to their doctor after they just had a baby, that they have an uncle with hemophilia. And I'm still amazed that it comes up at the last minute, and they're asking me about circumcision and what testing to do. And so this happens too often, happens at least a couple of times a year, in the Atlanta area, and I know it happens other places. And so I think, family planning, meeting with genetic counselors, I think is really important. So we make sure that we're communicating with the doctors and it doesn't become an emergency at the last minute, obviously potentially putting the baby at risk for intracranial hemorrhage at birth or receiving, factor early in life. And so, a lot of times women's periods get better after pregnancy with bleeding disorders. One of the things that we know is still an issue is postpartum hemorrhage. There have been a number of studies looking at the rates of postpartum hemorrhage. They're slightly higher in those with von Willebrand disease, probably somewhere in the 7 to 10% range. And postpartum hemorrhage can be quite scary, and women can bleed very rapidly. And so being at the right center with the right care is really important. And obviously alerting the provider that they have a bleeding disorder is very important. So I think that's important to make sure we're coordinating the care and also managing the post-delivery care, because nothing is more difficult for a woman if they're very anemic trying to breastfeed their child or trying to take care of their child, going on 2 or 3 hours of sleep. We know that the same type of bleeding that you have with menstruation, this sort of irregular bleeding, can happen around the time of menopause as well. And so that's when irregular bleeding can happen again. And so that's something that, again, providers should be alerted about. I think we know very little about perimenopausal bleeding. And we know very little about what the effects of aging is on women specifically with bleeding disorders. We think there might be a protective effect if you have low von Willebrand factor and factor VIII with regards to cardiac disease, but we're not sure. That really hasn't been studied. It's only recently been studied in males. And so I think that'll be something interesting to study in the future. So all those are things that sort of women have different challenges at different stages of their life. And I think the most important thing is to communicate clearly with the provider. The providers that they interact with may not ask them these things, but they should always bring it up to alert them for the potential that may bleed with procedures. Because I think oftentimes, unless somebody asks you, it may not be brought up.
Thinking about 2017 and beyond, regardless of, again, von Willebrand's, hemophilia, a rare factor deficiency, what do you see as the biggest advocacy challenge for women with bleeding disorders, again, this year and looking ahead a little bit? And likewise, what would be the biggest clinical or management challenge this year and in the years to come?
Well, I think one of the things I think is going to be critically important is everybody making sure that whatever healthcare we end up with, that birth control pills being provided for free is a big part of it. But a lot of people don't realize, and I think that's the problem with a lot of politicians, they don't realize that a lot of girls and women are on birth control pills to regulate their heavy or irregular periods. It's not for birth control alone. And that's, we prescribe hundreds of prescriptions a year specifically for management of heavy menstrual bleeding. We had over 300 visits in our 3 hospitals just with adolescent girls with heavy periods. And so I think that's critical. So I think getting that information out is important because there are a lot of people that don't understand that. And I think if they did, and they knew people in their district that had that issue, I think they would back off, because I think that's a critically important part of the healthcare. I think in the next couple of years, I think it's going to be really important that we really put out good, solid data and run very good clinical trials so we can truly show that the strategies that we do, the collaborative efforts between the hematologists and gynecologists, all of these lead to improved outcomes. Because I think, not so much in this country, but in many other countries, any kind of initiative, programs, they need to demonstrate that their outcomes are better than if they didn't do any of these things. And I think we haven't done a good job in that in the past. We all do things individually and show and, say, well, yeah, it worked really well in these girls. But I think we need to publish that data. We need to evaluate how we can do better. And I think that's part of the effort that we're going to do with this Athens Dream Award. We're really trying to highlight those strategies that work. And that way we can make sure the health insurance, the insurance companies pay for those strategies because they don't know what works if it's not published in any sort of, if it's not published on PubMed. They're reluctant to pay for strategies that may or may not work. And so I think that's really important. And I think there's a lot of providers that are working together to look at different ideas, and particularly in the Foundation for Women and Girls Learning Action Network, because we really think it's important it's a good incubator for research ideas. So we can really get at some of these issues that we've been talking about for the last couple of years. I think there's a lot of energy in this, and I think a lot of us are very excited. We're all excited that all the pharmaceutical companies are interested as well, And then we're also very excited that all the foundations are all excited in tackling these issues for women with bleeding disorders. And so I think there's a good concerted effort. There's good funding for this. They provided research grants specifically related to women with bleeding disorders. And so I think that's really important. And obviously maintaining NIH funding and to allow people to continue to do their research early in their career is really important.
And I would agree. There is a lot of energy on the patient advocacy and patient conversations at meetings and what have you. It does seem as though there's a lot of positive energy around women with bleeding disorders and improving the overall care and quality of life. So to kind of conclude our conversation of two fellas talking ladies with bleeding disorders, what are some of the things that someone like me and the guys with hemophilia or the moms who are not terribly clinically impacted by being a carrier or what have you, but those of us who aren't directly affected but can understand what the women are experiencing in our community, what can we be doing, as allies, so to speak, to help ensure that we're doing our part in the same way that the clinicians and the patients themselves are doing their parts?
So I always find it interesting when I give these talks at meetings, and as we're talking on the phone, I say, what better people to talk about women with bleeding disorder than two dudes on the phone about this? So, we go to these meetings, and it's always amusing to me when I'll give a talk, and sometimes they have these closed-door sessions, and it's me and a group of like 100 women in a room, and it sometimes seems strange that I'm talking about periods and how bad it is to these women. So, I think it's important because that we bring in everybody in these discussions. Initially, there were a lot of closed-door meetings, and it made sense because the women wanted to talk about sensitive issues, and I think there's a role for that. But I like it when they have these talks in which everybody is invited to, because I've been excited when I see, older men with hemophilia really surprised that this bleeding tendency can occur in their daughters or their sisters, and they felt like they had no idea. And they talk about how they're going to bring their daughter in to get tested. I think they have a better understanding of the genetic inheritance. I still have men bring in their daughters asking me if they can get their daughters tested for carrier status, and I say, well, I can save you a lot of money today. She's a carrier. You have hemophilia, then she's a carrier. So I think bringing all these men to understand this, because I think, my sense is that obviously there was a lot of energy making sure we do a better job of taking care of men with hemophilia, and obviously the crisis of the 80s. There was a lot of energy of trying to rectify those issues and make sure we do a much better job and we don't make those mistakes in the future. I think now that we're doing a much better job of managing men with hemophilia, I think there's time, and I think we can say, well, we can also focus on the women. And I think for the longest time, I think we felt there were a lot of women that felt guilty talking about their bleeding symptoms. So I think it's important for the men to discuss those bleeding symptoms with the women in their family, because I think these women often minimize their symptoms because they feel like, well, my bleeding is nothing like what, my son is going through or my brother is going through, so I don't really want to bring it up. And so I think it's important that the men in the community have the conversation with the women in their family, and they also reiterate to them that, you need to get tested. You should go on these websites, look at these tools, and look at your tendency to bleed. And go to them and say, well, before you get pregnant, you really should go talk to a genetic counselor. You really should consider getting your factor level checked and going to see a hematologist and talking to them about your bleeding symptoms, because it may be more than just the coincidence that you have, some bleeding symptoms. So I think the men can definitely support the women in making sure they take care of themselves, because I think for the longest time they've been helping take care of the men with hemophilia, and they've done a great job, obviously. And so I think it's up to them to help support those women in the community.
Well, Dr. Sidonio, thank you very much for this conversation. It's interesting to discuss this with you and to hear your perspective. It's an exciting time. It sounds like it's an exciting time to be a clinician treating women with bleeding disorders. And from an advocacy standpoint, seeing the level of excitement and energy in the women of the community is also very encouraging. So we'll keep each other updated and informed, and be curious to see how things evolve over the next several months and years.
Yeah. Definitely keep up the good work, getting the word out.
I will do what I can. Thank you again. I'm sure we'll be speaking sooner than not.
Okay.
All right. Take care. Bye.
All right.
Thank you to Dr. Robert Sidonio for appearing on episode 3 of Ask the Expert. I know I learned a little bit more than I knew going in about the world of women with bleeding disorders. I hope you did too. And if you're curious about any of the resources or websites that he mentioned during the conversation, you can find links to all of those in the program notes for this episode, as well as on the Ask the Expert website, which you can find through bloodstreammedia.com. That's it for this episode. We'll be back next month with another expert and more questions here on Ask the Expert.